Hello, everyone. So let's continue with this set of chapters regarding antimicrobials. We're going to continue now seeing UTI infections. So let me just share the screen. Okay, here we are. So regarding UTIs, is the second most common infection. On first place, we have upper respiratory tract infections. That'll be the first place, followed by UTIs. Regarding UTIs, is more common on females than males. And the reason to be is because of the length of the urethra. On females, the length of the urethra is shorter, so it's easier to bacteria to go to the urethra and invade the bladder. Okay, we're going to jump this one. Now, regarding bacteria that produces UTI, the most common one is E. coli. E. coli is a bacteria that you're going to find in the GI tract system. And the most common cause of E. coli jumping from the GI tract to the urinary tract, most of the time is lack of proper hygiene. In the hospital, the most common bacteria, I'm going to highlight, no, doesn't want to. Let's take this one away. So in a hospital setting, the most common ones are Klebsiella, Proteus, and Enterobacter. And it's the same reason. These are bacteria that usually they colonize the GI tract, but for lack of a proper sterile technique, when a healthcare provider is putting a Foley into the patient, they push this bacteria into the bladder. Other ones that may mention in case scenarios, that will be Pseudomonas, Staphylococcus, Enterococcus, and E. coli. Again, the most common antibiotic, and we mentioned this in the last chapter, is trimethoprim with sulfamethoxazole, followed by, and this is a new one, nitrofurantoin. Depending on the situation, depending on the patient, we choose between one or the other. Okay, so let's talk about the different types of UTIs they may put on the case scenarios for you to answer. Acute cystitis, this is an inflammation, well, the name is inflammation of the bladder. So here we have dysuria, is painful. It's a burning sensation when the patient goes and pee. Urinary urgency, that means that when they need to go, they need to go. And the problem is that when they go, it's only a few drops that come out. And it doesn't make sense if you compare the sensation that they had that they need to pee and then they go and it's only a few drops. Urinary frequency, that means that they go often, more than usual. Suprapubic discomfort, there's pain in the pelvic area. Pyuria, this is pus in urine. Usually we see this under a microscope. When we can see it with a naked eye, then we're talking about something more complicated than just acute cystitis. Bacteriuria, this is bacteria in urine, and this one we do a urine test, and that's where we're gonna see that, and also under the microscope. Regarding the treatments, can be a single dose, can be a short course treatment, 3 days, or the conventional 7 days. Now, acute uncomplicated pyelonephritis, this is a UTI that is more severe than the acute cystitis. Usually pyelonephritis, we're talking about an infection going up to the kidneys. So we're talking about a kidney infection. And this one is more common in young children. because of the immaturity of the tissue of the urethra and ureters. Older adults, because of a lack of a proper hygiene, they cannot take care for themselves properly. And women of childbearing age. Same thing, we're going to have the classic symptoms of dysuria, urinary frequency, urgency, and all that. But we need to have here fever. Patient will have fever. They're going to have chills. And for us to make a diagnosis, severe flank pain. And on this one, basically what happens is that we put our hand on the back of the patient on the lower back, left or right, and we tap with our hand over that area, and it's very painful, very, very painful. So that's how we know that the tract infection went all the way up there. Again, the bacteria, E. coli. Now, regarding complicated UTIs, this term is used when the patient has a modification regarding the urinary tract, a modification that was caused, by a cancer, a benign cancer, like prostatic hyperplasia, uh, kidney stones too. Well, nephrocalcinosis, this is calcium in the kidneys. Tumors, any change on the length, on the, sorry, not the length, any change on the quality of the ureter or urethra, like a structure, something, probably they put a catheter in there and they damage the tissue, so now we have a scar. So the scar is gonna affect the lumen, that's the proper word, the lumen of the urethra or the ureter. Or maybe they have a catheter, a Foley catheter. So every time we have a change in the quality of the lumen of the urinary tract, and they get a UTI infection, they fall under complicated UTIs. Symptoms are still the same, but here we're gonna add bacteremia. That means bacteria was able to get all the way into the blood system, and because of that, septic shock, where patient's gonna have high fevers, but then blood pressure starts dropping, and they start having generalized edema. And just like any other shock, the treatment you always start with the EpiPen. We need to raise that blood pressure first. So how can bacteria, unlike acute cystitis, pyelonephritis, the complicated UTIs, here they are able to get into the bloodstream? The thing is, because there's something blocking the flow of urine, urine cannot flush out bacteria properly. So the bacteria is going to get stuck somewhere in that tract system, and it's going to be able to continue moving forward, going up to the kidneys. And from there, from the kidneys, because the type of capillaries that they have, with so many fenestrations, with so many openings, they can jump into the blood system. Regarding recurring UTIs, 20% of patients will have a relapse with the same bacteria. And usually this will tell the doctor, hey, you know what? They might be an abnormality or a change in the quality of the lumen of the urinary tract. Now, reinfections, patients that recover and then after a couple of weeks they have another UTI. This is 80% of the times. Usually it's acute cystitis, lower urinary tract, the bladder, acute cystitis. And most of the time is related to sexual intercourse. So we're gonna see reinfections, more commonly on younger females. Now let's jump to males, acute bacterial prostatitis. So here we have inflammation of the prostate. Most common bacteria, you guessed it, E. coli. And just like the female is gonna have dysuria, urinary urgency, urinary frequency. Nocturia means that the patient is gonna get up more often during the night to pee, when usually someone without infection will sleep through the whole night. In this case, because of the sensation of urinary urgency, they'll start getting up more frequently, 2-3 times during the night. The most frequent cause for bacteria to reach all the way where the prostate is usually is because it was pushed by a Foley catheter. That's the most common cause, followed by some type of urethral surgery, or same thing, surgical procedures like prostatic resection due to a benign tumor. So when a male patient has bacterial prostatitis, we have to think that there was some type of manipulation of the urethra, most commonly surgical, and the bacteria E. coli. Okay, so after that brief explanation of the different types of UTIs, we're gonna add to antiseptics. Again, I didn't mention antibacteria or antibiotics, antiseptics, and that's nitrofurantoin and methanine. Methanine, sorry. Nitrofurantoin is brand name. The most common one is macrodantin. This is the most common brand name. Depending on the concentration of this antiseptic, can be a bacteriostatic, and we have mentioned that they don't kill the bacteria, but they don't allow it to multiply anymore. And a high concentration is going to be bactericidal. So that means high concentrations, they kill bacteria. Nitrofurantoin is advised for lower UTIs, like we mentioned, acute cystitis, prophylaxis, someone that is going to have some type of a surgical intervention, and we want to prevent a UTI or recurrent UTIs. So those are the common uses for nitrofurantoin. The adverse effects, GI tract, because it's a pill, so it's going to be MVD. Regarding pulmonary actions, we're going to have irritation on the windpipe. Patient may complain eventually of, a sore throat, stuff like that. Regarding hematology, every time you see hematology effects and they're not specific, go with your anemias and penias. The highlight, nitrofurantoin, regarding adverse effects, it will be peripheral neuropathy. And we mentioned here the peripheral nerves, they lose the myelin sheet that protects them. So now they're exposed to the environment, and that's going to produce irritation. Most of the nerves, peripheral nerve, they're in charge of a sensation. So the patient's going to start complaining about pain. Pain on the fingertips, pain on their toes. They're going to tell you they feel like ants crawling under the skin, and they'll have different ways of describing, a sensation that it's not obvious to the eye, but it bothers them a lot. They can eventually they'll start talking about sharp pain and then numbness. So when this happens, the numbness is because the nerve, the axon, is dead. It's unable to transmit anymore, and at that point, the damage is irreversible. Long-term use of nitrofurantoin, just like any other drug, it would be hepatotoxicity. Rare, very, very rare, can cause birth defects. And the reason I'm highlighting this is because nitrofurantoin is very common on to treat UTIs on female patients that are pregnant, because this medication, it doesn't get absorbed by the body. It goes directly. It's water soluble. It's basically water soluble, so it's gonna go directly to the urine, and it's gonna change the environment of the urine, make it less pleasant for bacteria. That way, bacteria doesn't multiply. So that's the reason I'm having birth defects. Less likely, because nitrofurantoin is one of the first options regarding UTIs on pregnant patients. Methamine, the way it works, methionine, it breaks down into ammonia and formaldehyde, and that is gonna cause the bacteria to break down the proteins of the bacteria, protein from the wall, protein from the membrane, and functional proteins. Same thing, usually methamine is used on chronic. That means a patient that has constantly UTIs, acute cystitis, well, not even acute cystitis, now it'll be a chronic cystitis. And it's not advised during kidney and liver failure. Why? Because again, this medication, when it goes into the body, it's gonna break down into ammonia and formaldehyde. Who's in charge of preventing damage to the body with that type of substances? That will be the liver. So if we have a patient with liver failure, this patient is going to be unable to control the levels of ammonia and formaldehyde in the body. So they're going to accumulate, they're going to increase, and that can affect the patient. And same thing with the kidney. The kidney is in charge of eliminating those substances. So if the kidney is unable to eliminate those two substances from the medication, same thing, they're going to accumulate, and that will damage the integrity of the patient's health. Regarding interactions, alkalizers, don't mix methamine with medications that alkalines the urine, because that will increase the amounts of ammonia and formaldehyde. And don't mix it with sulfonamides. And we mentioned sulfonamides is the one of the drugs that is used for UTIs. If you mix it with methamine, sulfonamides will be converted into crystal, and we mentioned this term is called crystalluria. So the patient will be peeing crystals, and it's very painful. Okay, so regarding this chapter, that is all. I'll be seeing you soon, and thank you for your attention.